Welcome to the Deep Dive. Today we're looking at something huge. How AI is changing healthcare. And we're starting with, well, just an incredible story.
It really is. It's about a young boy, Alex. For 3 years, just imagine 3 years of chronic pain, trouble walking, teeth grinding, just exhausted.
And his parents took him everywhere.
17 different doctors,
Yeah.
specialists, dentists, neurologists, PTs.
Yeah.
Nobody could figure it out. No diagnosis.
17. That's
Huh?
desperate. So what happened?
His mother, Courtney, she was completely stuck. So she did something, well, pretty unconventional. She gathered up all the notes, MRI reports, everything, and fed it all into ChatGPT.
No way. A consumer chatbot?
Yep. And it suggested tethered cord syndrome. It's linked to a hidden form of spina bifida. She took that idea to a neurosurgeon.
And it was right.
It was right. The neurosurgeon confirmed it, found the subtle signs like a birthmark Alex had. Diagnosis, finally.
It's honestly unbelievable. A chatbot succeeded where 17 experts didn't. So our mission today is to unpack that. How is this possible?
Exactly. We need to understand the technology behind these large language models, or LLMs, and also multimodal AI. They're really shaking things up, moving medicine towards being more proactive, more personalized.
Okay, so where do we start? The tech itself.
I think we have to. This isn't like those old chatbots from the 60s like Eliza. The progress really just in the last, say, 3 years has been explosive.
And that's down to?
Mainly one big architectural innovation, the transformer architecture, came out in 2017.
Right, I've heard of that. It uses something called self-attention. What does that actually mean? Is it just like a super fast search?
No, it's more fundamental than that. Self-attention lets the model weigh the importance of different pieces of data dynamically. Think about it like reading a huge patient file, hundreds of pages.
You'd get lost or forget something from page 10 by the time you hit page 150.
Exactly. Self-attention helps the model not forget. It can connect that weird symptom on page 10 with the lab result on page 150, even if they're far apart. It captures those long-range connections.
Okay, that makes sense for sifting through mountains of text like medical records. And these big AI models we hear about, ChatGPT, Gemini, Claude, they're built on this.
They are. We call them foundation models. They're huge, trained on massive data sets, and adaptable. And crucially, they're generative AI.
Generative. So they don't just classify things like, is this mole cancerous or not? They can actually create things.
Precisely. Older AI was mostly discriminative, sorting data into buckets. Generative AI learns the underlying patterns so well it can create new, novel content, new text, new images.
Or new drug designs, maybe?
Exactly. Or synthesize information in a new way like it did for Alex. And the reason it feels like this happened overnight is this scaling discovery.
Which is?
Basically, researchers found that with transformers, if you just make the model bigger, feed it more data, and throw more computing power at it, it just keeps getting better.
Huh. Unlike older methods, that would plateau.
Right. They hit a ceiling. Transformers seemingly don't, or at least the ceiling is much, much higher. So that's the engine. Now, how does this engine help patients and doctors?
Let's start with the patient side. How are these LLMs changing things for, us?
Well, one big way is making medical information more accessible. Imagine using a chatbot to ask questions about your own health records, your EHR, in plain English.
Instead of trying to decode doctor speak.
Exactly. Or taking a complicated hospital discharge summary or a, frankly, terrifying pathology report and getting a simple summary you can actually understand.
That alone would be huge for reducing anxiety.
Absolutely. And we're seeing interesting potential in mental health, too. Chatbots might help reduce stigma, make it easier for people to take that first step.
And maybe reach groups who don't normally access traditional therapy.
There's definitely potential there. Research is showing increased referral rates in some studies, particularly for underrepresented groups.
Okay, let's circle back to Alex. You said the AI synthesized information. How did that play out with his symptoms?
So Courtney put in all these disparate things, the pain, the exhaustion, dragging his leg, and crucially, that detail about not being able to sit crisscross applesauce.
Which might seem minor to one specialist, but maybe not to another.
Or maybe no single specialist would connect at all. The dentist sees the teeth grinding, the neurologist sees the headaches, the PT sees the gait problem. They're all focused on their piece.
Specialization creates blind spots.
Arguably, yes. The AI, trained on maybe millions of medical texts, acted like this incredibly powerful medical search engine, but one that could connect things. It saw how the inability to sit that way, the leg drag, the pain, all pointed towards a structural issue, the tethered cord.
So it's not that the doctors were bad, it's that the problem required a type of synthesis that's maybe beyond typical human capacity in complex cases.
I think that's a fair way to put it. Human brains are amazing, but synthesizing across 17 specialties worth of data in real time, that's where AI can shine. But it's not just for patients, it's changing clinicians' job too.
Right, the administrative burden. Documentation is a huge time sink.
Massive. So AI scribes are starting to appear. They listen to the patient visit, draft the note, maybe even handle pre-authorization requests or scheduling.
Freeing up the doctor to actually focus on the patient.
That's the goal. And in some research settings, LLMs are actually performing as well as or even better than humans at things like taking patient histories or following diagnostic steps.
Wow. Are we heading towards AI medical teams?
It looks like it. Some companies are building what they call agentic systems. Think of a main AI coordinating a team of specialized AIs, one for meds, one for labs, one for imaging.
Like an internal checks and balances system?
Kind of, yeah. A way to improve accuracy and build in safety through redundancy, like having multiple specialists consult, but instantly, and done by machine.
Okay, so that's language. But medicine isn't just text. There are scans, x-rays, genetic sequences.
Which brings us to multimodal AI. Medicine is inherently multimodal. It uses images, text, genomics, sounds. Multimodal AI learns to understand all these different types of data together.
How did that work? How do you teach an AI to connect a picture with words?
A key breakthrough was a model called CLIP, Contrastive Language Image Pre-training. It basically learned to map images and their text descriptions into a shared space. So the AI understands that this X-ray image corresponds to the concept described by the words fractured tibia.
I can see how that would be powerful in, say, pathology, looking at slides and reports together.
Exactly. Models like PathChat or KikoNCH are already doing this, integrating slide images, pathology reports, even genomic data to improve diagnostic accuracy.
And this ability to fuse different data types must be driving that shift you mentioned, from reacting to problems to predicting them.
Absolutely. It enables proactive, personalized care. We're moving monitoring out of the hospital. Your smartwatch might detect atrial fibrillation. There are experimental wearable ultrasound patches.
Oh, wearable ultrasound.
Yeah, early days, but it's happening. Or think about implantable sensors checking temperature to detect kidney transplant rejection way before the patient feels sick.
So we're forecasting problems. At what scale can AI do this?
Pretty much all scales. Down at the molecular level, the big one is AlphaFold 2 from DeepMind.
That's the protein folding thing, right? Won a Nobel.
That's the one. It predicts protein structures with incredible accuracy. The newer version, AlphaFold 3, even predicts how proteins interact with other molecules, like potential drugs.
Which means we can predict how a specific person's genetic mutation might affect a protein and design drugs faster.
That's the promise. Truly personalized medicine, starting at the molecule. Then you move up to the organ level. AI analyzing ECGs to predict heart problems, or even using retinal scans.
Pictures of the back of the eye.
Yeah, using retinal images to predict heart attack risk, sometimes more accurately than traditional methods.
Okay, but let's bring this home. How does this forecasting power actually change care for, say, someone getting screened for cancer? You mentioned a lung cancer study.
Right. This is a fantastic example of precision in action. Standard practice for lung cancer screening involves yearly scans for high-risk people. But what if some people are lower risk, even within that group?
Could they be scanned less often? Reduce radiation, cost, anxiety.
Exactly. The goal of this study was, can we safely identify people with lung nodules that look benign and move them to screening every 2 years instead of annually?
So they compared an AI model, a deep learning algorithm called LCP-CNN, against the standard methods.
Yes, against a statistical model and the official guidelines radiologists use called lung aids.
And how did the AI do? Did it just edge them out? Or?
Oh, it wasn't even close. The AI model, LCP-CNN, was significantly better at predicting which nodules were actually cancerous later on. Its predictive power, measured by AUC, was 0.87 compared to 0.79 for the stats model, and just 0.69 for the current guidelines.
Okay, higher prediction score is good. But what about safety? What if the AI tells someone to wait 2 years and it's wrong?
That's the crucial question. They calculated the risk of delaying a cancer diagnosis by 1 year. If they use the AI to switch about 2/3 of low-risk people to biennial screening, the absolute risk of a 1-year cancer delay with the AI model was incredibly low, 0.28%, just over 1/4%.
Wow. And the risk using the current standard guidelines?
Almost a full percent. 0.97%. So the AI made that decision to wait an extra year, roughly 70% safer for those specific low-risk patients.
So it's not just predicting better, it's allowing for genuinely personalized, safer screening schedules based on individual risk, not just broad guidelines.
Precisely. It shows we can tailor care after the initial screen with a level of precision humans just can't match using current rules.
Okay, so if the tech is this good diagnosing Alex, personalizing screening with near zero risk, why isn't this everywhere? What are the roadblocks?
Well, the big scary one is accuracy, specifically the hallucination problem. These generative AIs can just make things up.
Like citing research papers that don't exist.
Exactly. Or inventing treatments. In medicine, you absolutely cannot have that. Factual accuracy has to be paramount. It's a major safety concern.
And then there's bias, right? If the AI is trained mostly on data from one group of people,
It might not work as well for others. It might miss diagnoses or suggest wrong treatments for different populations. We need massive, diverse data sets to train these models properly and ensure they're equitable. Frankly, many current models probably don't meet general medical safety standards yet.
so safety and bias are huge. What about getting these things approved? Regulation must be a nightmare.
It is. The FDA is trying, but regulating something that can change its output constantly, like these generative models do when they're updated, is tough. It's not like approving a static drug or device.
Is there any mechanism for that? For approving AI that learns and changes?
They've introduced something called a predetermined change control plan, or PCCP. The idea is a vendor gets approval for the initial AI and for a plan outlining how they can update it within certain agreed-upon limits without needing full reapproval every single time.
Trying to keep pace with innovation, basically.
Trying, yes. But even if you get approval, actually integrating this AI into hospitals is another massive hurdle. Healthcare IT is notoriously clunky, outdated, systems don't talk to each other.
So plugging in a cutting-edge AI isn't exactly plug and play.
Not even close. It's a huge technical and workflow challenge. And then you have the doctors themselves. How does their role change?
Right. If the AI is doing the diagnosis or documentation, what does the doctor do?
The thinking is they become more like an orchestrator or director, managing the AI tools, handling the most complex cases, overseeing the process, and importantly, holding the ultimate responsibility and liability.
That's a big shift. And who pays for all this? These AI systems must be expensive.
Extremely. And that's maybe the biggest barrier, especially in the U.S. system. The current fee-for-service model with CPT codes for procedures doesn't really have a way to bill for using a general AI diagnostic tool.
So if the AI saves the hospital money by preventing errors or saves the doctor time, there's no direct way to get paid for using the AI.
Generally, no. We probably need a shift towards value-based care, where reimbursement is tied to outcomes and overall cost savings. But proving that value is complex and takes time. Plus, you have skepticism from doctors' worries about job security, loss of autonomy, needing training.
It's a lot of friction.
A huge amount. So, to sum up, we're seeing this incredible potential. AI is driving this shift towards proactive, personalized medicine. The tools, LLMs, multimodal AI, the deep learning for screening they work, they can be clinically superior.
There's this massive gap. We have AI that can personalize lung screening down to a fraction of a % risk, scientifically validated.
Right, and yet Alex's mom had to use an unregulated consumer chatbot to get a diagnosis missed by 17 specialists.
It's a stark contrast, the speed of AI development versus the crawl of clinical implementation.
Exactly. The tech is arguably ready for some tasks today, but the system regulation payment integration trust isn't.
So the final thought for you, our listeners, is really about this tension. How do we navigate this? How do we ethically balance the potential life-saving urgency of using tools like the one that helped Alex, even if they're not fully regulated yet, against the absolute need for scientific rigor, safety, and equitable access before we deploy them widely?
That's the tightrope we're walking. Finding that balance might be the defining challenge for medicine in the coming decade.